morning, everyone. Welcome to the next webinar on BIOS. My name is BijaySingh, current president of the BIOS. We've got extremely good faculty with us for the fairly common topics that, not just as a hand surgeon, but you would see, yes, there is a couple of specific ones, but it's good to know the overall view. So I'm going to pass it now to Abhi, who is coordinating this. So just for technical aspects, myself, Sunil, are going to be the technical host as well. The chat line is open, so please put the questions into there, and we will try and capture and get them answered towards the end, after two talks. And then at the end of this, we're planning to send a SurveyMonkey feedback form. So if you are a member of the BIOS, then you will get it through the BIOS email. If not, I would suggest that you put your phone number or email address down so that we can send it to you. With that, I'll hand it to Abhi. Thanks, Abhi.
Thank you, Prof. Hi, everyone. So we will kick off our hand and wrist webinar today. We have some excellent faculty, some senior members of the hand surgery community here talking. And helping me moderate the session is Mr. Sunil Garg, who's the Honorary Secretary for BIOS. We will start off with the first talk, which will be run by Mr. Saurabh Agarwal. He is my consultant colleague at the Princess Royal University Hospital, part of King's College. We call him the professor because of his vast knowledge, and I'm looking forward to listening to his talk today. Right, thanks, Saurabh.
Yes, thank you, Abhi. Thanks, BIOS, for your very kind invitation. Let me share the screen. So, am I there, Sunil?
Absolutely.
Yes,
spot on.
Right, thank you. So, I'm Saurabh Agarwal, upper limb surgeon at Princess Royal University Hospital. Mr. Guliharand is my other colleague. Right, so talk is on scaphoid fractures and a bit about scaphoid non-union. It's a big talk, so I'm going to whiz through some slides and others I'll stop and pay a little attention to. So we know it's a hyperextension injury. Relevance, footballers, especially the goalkeepers, the linesmen, because when they're trying to catch a football, hand will go into hyperextension and they'll get this injury. So every year I'll have one patient from crowd, a spectator, who's come with a wrist pain after a football match, and surprise, surprise, it's a scaphoid fracture. So this is what we are going to discuss in the next few slides: how you diagnose it, imaging, indications to fix, technique for fixation, approaches, and immobilization. Diagnosis, important point in this slide, it's an intra-articular fracture. So patient is going to have hemarthrosis. Significance, in the hand, on the radial side, it'll be, you'll not see a lot of bruising, and there's no specific site of pain. Remember that. X-rays, importance, 16%, 1 in 7 patients. Fracture is not picked up on initial X-ray. So, so if you're suspicious, give a plaster slab, follow up 2 weeks, a repeat X-ray. Even then, if there's pain in the snuff box and over tubercle, X-ray is not conclusive, get an MRI scan. Now, these next 3-4 slides are important. In terms of X-rays, scaphoid being a bean-shaped bone, you need specialized view. So importance for ulnar deviation, PA wrist view, scaphoid becomes fully extended. So you can see it in its entirety. So if there's any subtle fractures or oblique fracture lines, you will pick up on this view. So if you were given one view to diagnose a scaphoid fracture, this is the view you must have. Lateral view, again, scaphoid is superimposed on lunate. But important relevance here, you have to see the relationship of proximal pole of scaphoid to proximal pole of lunate. So that's it. This is a normal X-ray, so you can see scaphoid is sitting in the lunate if you like. In subtle scaphoid lunate injuries, scaphoid will sublux dorsally. So this relationship is gone. That helps you to pick up subtle scaphoid lunate injuries. 45-degree supination view. So if you see, you can see the proximal pole here, not the distal pole, just the proximal pole. Relevance, if you're doing your screw fixation for a waist or a proximal pole, this is the view you have to do in your theaters to make sure screw is not broad at the proximal pole level. Pronation is the other way around now. You can see the distal pole, not the proximal pole. So this view will tell you if the screw is prod on the distal pole. So you need all the 4 views to diagnose, to treat them in theaters, and even post-operatively to make sure screw is not prominent. Then MRI, as I was just saying, in acute injuries, if X-ray is not conclusive, get an MRI because it will pick up scaphoid edema. It will tell you those subtle fracture lines. And also very occasionally I've seen a scaphoid lunate injury can also happen with scaphoid. Normally partial and a very rare, but MRI will pick up. So order an MRI. CT. CT is very important. And it's my best friend for my scaphoid work, for non-union work especially. So you can pick up those fracture types. So it's not always a transverse fracture. The patient can have oblique lines. Sometimes it's hard to know whether it's a waist or a proximal pole. CT comes to aid because if it's a waist, it's a volar approach. If it's a proximal pole, it's going to be a dorsal approach. So CT, very important. Humpbacks. So we'll see in the other slides, an unstable waist will go into a humpback. And I need to know how much bone loss is there to plan for a graft. In terms of graft, 98, 99 cases out of 100, you'll get away with a distal radius graft, very occasionally a iliac crest graft. So that's where CT helps you in pre-op planning and consenting. Prognosis. So for the factors discussed above, you can tell your patient about prognosis. Healing. So we know in a waist, plaster cast is roughly for 6 weeks. Now at 6 weeks, patient comes to you out of plaster, patient is in still some pain or not a good historian. So you can't give a plaster indefinitely. In those cases, I, at least in my practice, will take plaster out and get a CT scan. And if CT shows some bridging trabeculae in, let's say, even 60% of scaphoid, I know it's going to heal. So CT important for many reasons. So this is an important slide and a take-home message. Herbert classification, we all know. A, stable, B, unstable. You start from distal pole to waist to proximal pole to pari-lunate injuries, followed by a comminuted scaphoid. And then type C and D, delayed union and non-union. I'm going to skip this slide. I'm sure you all know about it. Plaster immobilization. There's no role of a scaphoid cast unless for some reason you can't operate on a patient, medical issues, or patient doesn't want it. Otherwise, Colles cast is as effective as a scaphoid cast. So they've done studies where if a thumb moves, it creates some movement at the scaphoid fracture site, but not enough to lead it into a non-union. So no role of a scaphoid cast. Plaster treatment, how long is a piece of string? So waist, roughly 6 weeks, all those oblique fractures, proximal pole, around 10 weeks. And as I said, anything beyond, you take the plaster out, get a CT scan, it'll give you an idea about healing. Indications for early fixation. So this is an important slide and an exam question. So all those pari-lunate injuries, all those displaced fractures. So you may be asked in exam, define displacement. So it's 1 millimeter, but you, at least I can't tell you on an X-ray if it's 1 millimeter, millimeter and a half. If I see a displacement, if I see a subtle step in my books, it is a displacement. CIS is an intra-articular fracture, like your intracapsular. Hydrostatic pressure, fluid goes in, CIS will form, like in your hip arthritis, geodes. So if you see CIS, that fracture is not going to heal up. Don't waste that patient's time, put them on a list and get on and do the surgery. Proximal poles, 30% non-union, we know that. All of them need surgery. Delayed presentation, very important because I see this fairly commonly at PRU. Young man, motorcycle accident, dismissed as a sprain, and they turn up in 4 weeks, 6 weeks, 8 weeks. High chance of non-union, part of consenting, and get on and do the surgery. So these indications you should be well aware of. This is another exam question, undisplaced waist, fixation versus plaster. Now, this is a discussion you need to have with your patients in clinic. If someone is young, wants to go to works in central London, can't afford to have plaster casts, serial visits to hospital, then yes, you can talk about percutaneous fixation. You can quote the evidence. Healing is quicker, 7 weeks, time to work will be a bit quicker, less hospital visits. But at 2 years, there's no difference whether you treat it in a plaster or a percutaneous screw. And remember, fixation, like any surgery, comes with its baggage. And infection problems, screw penetration problems, general anesthesia. So that's a discussion you need to have with the patient and together make a decision. If you decide on a percutaneous fixation, that's one of my patients, you just mark the scaphoid tubercle. Once you know on your II stab incision, pass the wire, whatever you measure, take 2 millimeter less, use any variable pitch screw, and that's it. In terms of open approach, for a waist fracture, it's a volar approach. For a proximal pole, it's a dorsal approach because it's hard to see proximal pole from the volar side. So let's see the volar approach. So it's a FCR approach centered on scaphoid tubercle. And this little fellow there, that's your radioscaphocapitate ligament. That's your sling ligament. This is where the distal half of scaphoid kind of flexes and sort of gives you that humpback, if you like, or displacement, if you like. Practically, that's the incision. If you're not using a bone graft, this picture is just there to tell you that you go right down from skin to the capsule to the bone so that your radioscaphoid ligament goes into 2 halves. And in the end, you do an en-masse stitch and the ligament heals up. So example there, 24-year-old, hyperextension injury. And you can see on your CT scan, especially your sagittal CT, there are cysts. And you already know when you're going to curate it, it'll create a bit of bone loss, i.e. a corticocancellous graft. So that's part of your consenting in the clinic. And these are some of the slides from one of my patients. So in exams, you're going to talk about who list, your consent, your positioning, your tourniquet, your antibiotics. Then you come to the incision, describe your incision, and same x-rays. Once I've curated it, there's a bit of a bone loss there, corticocancellous graft from distal radius. This is me showing that wire should go first, holding the 2 ends of scaphoid together. Otherwise, your graft will disperse. Then you put your graft and a thin cortical piece. Because if you put a thick piece, it takes a long time for bone to resorb and new graft to form. So very thin cortical piece. And then finally, I would use DBX at the graft site. You can use bone wax, whatever you prefer. Another example is just to say 46-year-old, same injury, get all your 4 views. So that's your supination view, proximal pole, pronation view to see your distal pole, your lateral view, and your you can see the whole extended scaphoid in your PA ulnar deviation view. And important here, prono-supination views in your post-op x-rays. So in your supination, 45 supination, you can see your proximal pole very clearly. So you know there's a clear daylight between your screw and your proximal pole. And in your pronation view, you can see that the screw is buried and is not penetrating on your distal pole. So anytime your registrar comes to you and say, oh, I think the screw is penetrating, think of your pronation supination view before you make a decision. Then let's come to the dorsal approach. For exam, you just keep it into simple, break it into simple steps. 3 steps. First, your internervous plane, your cutaneous, radial nerve, and ulnar nerve branches. So your skin fat, good flaps, nerves will go with those. So that's your first step. Second, deal with your retinaculum. Exam answer between 3 and 4. For scaphoid, it's you just incise the distal half of retinaculum. Third step, capsule. Again, for scaphoid, all you need to do is see the lunate, part of lunate and scaphoid. So it's not a burger flap, a modified Mayo flap, like a partial incision of capsule. And this is the picture I wanted you to, so this and this will correlate. So all I need to see is my proximal pole of scaphoid, and your screw has to go very close to lunate, not far away, which is where I marked with a pen. So if you can break it into 3 steps and mention this, I think examiner will be happy. So an example to go by, 29-year-old, so they're all young men, hyperextension injury, proximal pole fracture. Always get a CT scan if you're worried, if it's a delayed presentation, if it's a chronic injury, if it's a non-union. And these spurs dorsally tells you it's a non-union, it's not an acute injury, because proximal poles don't go into snack. So you will not see a lot of bone loss, a lot of humpbacks, as we'll see in the following slides. So I knew it was a non-union, so I'm already prepared about a cancellous graft. In terms of approach, we'll do a dorsal approach as discussed, graft from distal radius. And the reason I put this 1 year post-op, any proximal pole, your follow-up stops at 1 year, not 6 months, not 9 months, 1 year. That's
2 minutes. 2 minutes, sir. Thank you.
Okay, I'll rush. That's the time it takes for a proximal pole to heal up. So I'm going to rush, it's only 2 minutes. Non-union impending signs, if the fracture line increases or cyst forms, you know that's not going to heal up. Again, same thing here, cyst, big gap, you know it's a non-union. Causes of scaphoid non-union, natural history and treatment. Causes, remember, we've discussed about intra-articular fracture, like your neck of femurs, intracapsular. Blood supply, important discussion, comes from dorsal, 70 to 80% supply, all proximal pole dorsal supply. Natural history, this is the most important slide. If you want to take one take-home message, it is this slide. So waist, natural history can be stable or unstable. Unstable waist is unstable in terms of force transmission. So it's going to, this is the one which is going to give you a humpback, a dorsal spurs, dorsal osteophytes, cysts, and go on to progress into snack. As opposed to a stable waist, so if you see the X-ray radiograph there, you can see sclerosis. It happened a long time ago, but this is the one where transmission is good, so it's not going to drop into snack. So this one is your friend. Even after 5 years, all you need to do is a simple screw and a bone graft. So unstable waist, your humpback scaphoid, this is how it starts, and these are the schematic pictures. Distal pole starts flexing, dorsal spurs, further flexes, more spurs, more osteophytes. So these are the ones which need a lot of corticocancellous graft. How do you correct your humpback? Go from what? That's a normal scaphoid, humpback, you keep correcting by and hold it with a wire, then a graft. Natural history of stable waist, day 1 X-ray, year 5 X-ray if you like, sclerosis, but no humpbacks, no snacks. Non-union, again, I'm going to skip this slide. It is just what we have discussed. You correct it, wire, graft, and put a graft there. Proximal poles, they don't go into snack, but what they do is, if you see the sort of the X-ray, they get avian, then they get fragmentation. If they are fragmented, so this was again the X-ray we discussed before, spurs and then a screw. If they get fragmented, you think of vascularized graft. This is last 2-3 slides. So your same thing, I put it into words here, that in a proximal pole, humpbacks, disease, snacks doesn't happen. All you get is a dorsal spur, sometimes an articular surface wear on radial styloid. So I recently had a case, you put a scope in, you confirm that, and then you go on to do a styloidectomy and a proximal pole screw and a bone graft fixation. These are just vascularized graft. Indeed, I have never done one, even though I do 2 non-union proximal poles a year. Not a lot, but nonetheless, bring it up into discussion. You just have to just say the name of the vessel and you are done. I think that's the end of my talk. Just the last slide, Sunil. That's my website, guys. And I've done 5 sort of international Zoom presentations these year, all on FRCS. They're all 1 hour plus talks, very relevant to exams. So if you get time, go on the website, just click on my YouTube channel or lectures. They'll all come up as I've shown you. I think it'll help you, but if you get time. Good luck.
Fantastic.
And thank you very much.
Fantastic, sir. That's very, very good. Excellent. I'm conscious of time. Very quickly, just one question for FRCS Orth's exam and in general about the occult fractures. As you know, it's a big problem in A&E. You have someone with anatomical snuff box tenderness, they fall on outstretched hand, but X-rays are negative. Would you suggest a quick 1 or 2 a quick slice MRI scan?
Who is it for, Sunil, for the candidates?
question for you. What would you say they should answer? What do you think? What's your opinion on that?
Right. Okay. So as I was just saying, as you said, and it's a very important question. Scaphoids are dismissed as sprains, and that's why delayed presentation. And some of them will not even come for years, and they're going to snack, which is very unfortunate given their young age. I would personally, on a day one, if there's tenderness, I would just sit on it because resources. I wish I could get MRIs on all of those. I would personally put them in a slab. I would warn them of a potential scaphoid fracture, see them in 2 weeks. At 2 weeks, if they're still tender, but X-rays are not conclusive, then I'll definitely get an MRI scan, but not day one because of the resources.
Okay. Thanks very much, Saurabh. If there are no other questions, we'll move on to the second talk. Abhi?
Stop sharing, please. Saurabh.
Sorry, Prof Bijay?
You need to stop your share so we can move on to the next one.
Yes. Okay, done that, Prof Bijay. Sorry, yeah.
Thank you.
Great. Thank you, Saurabh. That was an excellent talk. We move on to our next talk with Mr. Ullah from Leicester. He's one of the senior hand surgeons who I've known for a long time. He's an excellent trainer, and I know from my time in Leicester that everyone wanted to work for him. So I'm looking forward to listening to this talk. He's also the captain of the consultants cricket team, and unfortunately was victorious a few times. But anyways, I'll let him crack on. Thanks, Mr. Ullah.
Talk today on perilunate injuries of the wrist. So these injuries are high energy injuries, and due to the complexity, it's not unusual for there to be a delay in diagnosis in up to a quarter of these patients. They're usually men, and it's important when trying to distinguish these injuries to be able to ascertain whether it's a lesser injury or a lesser arc injury or a greater arc injury. So the lesser and the greater arc injuries are defined by the forces that are transmitted through the wrist at the time of the injury. And with the lesser arc injuries, the force travels around the lunate and therefore involves both the ligament of the scapholunate and the ligament of the lunar triquetral. And with a complete injury, allows the lunate to dislocate volarwards through the space of Poirier. Whereas a greater arc injury, the force transmitted starts radially normally and can transmit it across into the ulnar styloid. So lesser arc injuries are ligamentous injuries, as I stated. And if a complete ligament disruption is achieved, and that's a stage 4 Mayfield instability, and the lunate can dislocate forwards, as you can see here, and sit within the carpal tunnel and cause median nerve disruption as well. In order to treat these, you need to reduce the lunate, repair both the scapholunate ligament on the dorsal aspect, and stabilize or repair the lunar triquetral ligament with either an open repair from the volar side or a reduction with K-wires. Greater arc injuries, which are more common, they can involve all the bones from the styloid, the scaphoid, the capitate, hamate, and the triquetrum down to the ulnar styloid. As well as that, they can also disrupt the ligaments of both the scapholunate and the lunar triquetral. They're far more common than the lesser arc injuries, and the transscaphoid perilunate injury is the most commonest variant and the one that you've probably heard of. So in these injuries, scaphoid waist fracture is in about 70% of them. Despite having a scaphoid fracture, you can still see a scapholunate ligament rupture in about 4%. Look out for the capitate fracture, and if you do develop a capitate fracture, it may be part of something called a scaphocapitate syndrome. And in this instance, the capitate fractures and rotates 180 degrees, and therefore the articular surface is pointing in the wrong direction. It can be a very subtle injury, which can be missed on a plain radiograph if you don't look for it. But the CT scan clearly shows the articular surface facing the wrong direction. As a consequence of that, avascular necrosis can be quite common. So as I stated, these greater arc injuries are ligamentous injuries. Ligamentous injuries can also occur on the ulnar side, and you can disrupt the lunate-cruciate ligament. They can present with nerve symptoms of either of the median ulnar nerves, and these are normally due to swelling or pressure, and improve after the dislocation is reduced. In order to diagnose this on plain radiographs, Galula's lines can be disrupted. So the line of the proximal and the distal row can be disrupted, and the carpal height can be reduced. The shape of the lunate also changes as the capitate dislocates. In order to treat these, I advise placing them into traction, giving the patients adequate analgesia or sedation, and following traction that allows the capitate to ride up. Extend the wrist, allows the capitate to sit back near the lunate fossa, and then pressure volarly on the lunate reduces the dislocation. And then place them into a back slab, observe their neurovascular status, and then plan for a definitive fixation on your next available emergency trauma list. Open repair generally has much better outcomes, and I do these through a dorsal and volar approach. Through the dorsal approach, you can visualize the scaphoid fracture, and any loose bits of cartilage can be removed. Scaphoid can be stabilized through a headless screw, and the scapholunate ligament can be repaired if needed. Through the volar approach, this reduces releases the median nerve and allows you to visualize the capsule and the tear within the lunate-cruciate ligament, which can be reduced and either repaired directly or more commonly stabilized with KYs ulnarwards. Occasionally, graft is needed if there's significant loss of bone, especially around the scaphoid. And this could be taken from the distal radius if needed. So in this example, the scaphoid's been stabilized with a headless screw, the lunate-cruciate ligament's been stabilized, and derotation wires also been added. I bury my KYs below the skin and place them into a cast below elbow. I remove the wires at about 8 weeks under local anesthetic in the clinic, and then the hand therapy commences following this. Results of these can improve up to about a year, and expect about 3/4 of the grip to return and about 100 degrees range of movement for those who have openly reduced. Delay to treatment will significantly affect the outcome, as will open injuries, and warn the patients that post-traumatic osteoarthritis is very common. Even those that present late should be treated with open reduction. There's reports of patients being done, following 35 weeks of presentation. Thank you very much. Happy to take any questions.
Perfect. Thank you very much, Amar. Excellent talk, but very, very relevant to the exam. I have a couple of questions, if that's okay. Common exam question, of course, and common scenario for all grades of orthopedic surgeons. What would you say a general orthopedic surgeon should do if this comes in the evening at about 7 o'clock? And what should be the exam answer as well?
Yeah, thanks, Abhi. I think with all dislocated joints, I think the minimum should be to try and reduce these joints. So I would expect my colleagues to try and take these to either in the ED. We're quite fortunate in our ED department. We can use Penthrox now and sedation. That actually allows us to do a lot more than we used to be able to do. previously and reduce that mid-carpal dislocation in these perilunates. It's very, if they're caught quite acutely, it's very rare for them not to be able to be reduced either in the ED department or under a GA with sedation, just like you do with your shoulder dislocations. And occasionally you'll get, just like with the shoulder, you get one that's difficult and they normally need a bit of muscle relaxant and they will reduce and then place them into a back slab because they need definitive surgery and all you've done is reduce the dislocation, but you haven't actually treated the injuries, which are the comminuted scaphoid fracture in a lot of these cases and the ligamentous injuries. That lunar-triquetral ligament gets forgotten about a lot of the time. So in our peripheral district hospitals that surround our area, we say that reduce them, send them to us, elevated. I'll happily fix them a week or so later in my next trauma list. But I think it's got to be recognized that this is more than just a dislocation for those perilunates, for the greater arc injuries. This is a ligamentous and a dislocation. You've just done step one by reducing it, and you have to do the repair. And you have to acknowledge the fact you have to assess the scapholunate and the lunar-triquetral and repair them in whichever way you want to repair them.
Perfect. No, thank you. That was a very clear answer.
The other things where I didn't mention in the talk, and I think for the trainees, obviously for the coming up to the exams, is learn the Mayfield classification. So you can have an injury, a wrist injury. Not all wrist injuries or not all greater arc injuries lead to a perilunate dislocation, and they go into stages. So the first stage of that greater arc injury and the lesser arc injuries is that you disrupt the scapholunate ligament first, and then the lunar capitate articulation disrupts in stage 2, and then in stage 3 the lunar triquetral disrupts, and then you get a perilunate, and then in stage 4 you can get a lunate dislocation into the space of peri and the carpal tunnel. So learn that classification and be able to talk about it. So it's a pattern of injury that goes around the ligaments.
Perfect. And the second question from me, which is slightly not related, well related but not quite the same. What do you do for people with isolated scapholunate ligament injuries?
If somebody presents acutely, I think half the trouble with these ones is them being recognized and presenting to an upper limb surgeon early enough. But all of these with a complete disruption, which is a dorsal ligament disruption of the scapholunate, I would always repair them. And that means opening them up dorsally and then trying to repair them with bone anchors or what have you, depending on which where the disruption is and which bone it's come off. And then protecting the repair as well with K-wires and leaving them immobilized for about 8 weeks. Now they do stiffen up a little bit, and that in itself will probably help in the long run. But chronic scapholunate instability is a much harder condition to treat. The results for surgery and outcomes are not as predictive, and there are some centres that are now reporting that actually their results are even for the ligament reconstructions are not as good as initially thought.
What would you do for the ones that come to you at 4 or 5 weeks?
Yeah, I think even up to a month, I would still try and repair them. I would observe. I would review them in theatre and try and repair them if I can, but warn the patients that actually they may not get a good result, and then long term, if several months down the line they're still symptomatic, then talk about doing a type of Brunelli for them if necessary. But even again, like I said, with Brunellis, look at the literature because the results for them are variable, and there's no long-term literature on how well patients do long-term with these.
Perfect. Thank you very much. I think there was one question on the chat, which was, I think you partly answered it anyways. What do you do with somebody with median nerve symptoms in the evening?
Yeah, most of the time these patients with median nerves are due to the dislocation. So when you reduce that and you elevate them, most of the time the nerve injury or compression improves. So I would ask them to elevate the hand as long as they've reduced it and observe it. And if like I said, if the following morning, if the patient still has significant nerve injury, nerve symptoms, median nerve symptoms, and then in theatre, then I would release the carpal tunnel with the volar approach, and then do my dorsal approach and repair the fractures and the ligaments anyway.
Perfect. Well, thank you very much.
Can I just go on that, Abhi? 1 second. So, hi, Amar, it's Bijay.
Hi.
Going on that further is, for example, if you're trying to reduce that and it doesn't reduce, because I can see where this question is coming from the trainees, is if you try and reduce it and it doesn't reduce, would you do a carpal tunnel release and push it back open, or would you leave it till the morning? I think that's where this guy was.
Yeah. Okay. Well, I think if you've made a decision that you've got a nerve compression and you've made a decision to try and reduce it, then I think you're duty bound to try and reduce it. And I think that I personally, it's really difficult answering a question when you're not a trainee. But I think personally, I would say the carpal tunnel approach. Most people are familiar with that approach. If you've got a complete lunate dislocation, so a lesser arc injury, that's actually quite easy to repair because all the capsular disruption's done for you, and for them not to be able to be reduced is quite rare, closed. But if you open it, then reducing that with traction and pushing the lunate back is quite easy to do. And for perilunates that are very swollen, you can't reduce most of the time. You can you can open them up. They're probably a little bit easier to go through the dorsal approach because the mid carpal row dislocates dorsally, so that's normally a bit easier, and there's less things to injure if you go dorsally.
Thank you, Amar.
Perfect. Thanks, Amar.
Thank you.
I don't think there are any more questions, so we'll move on to the next talk. So next speaker we have is Professor Tolat, who is one of the senior upper limb surgeons at Medway Maritime Hospital, and he's recently been elected president, future president of British Indian Orthopaedic Society. So congratulations, and I'll let you crack on with your talk. Thank you.
Hello, good morning, everybody. It gives me very great pleasure to talk on this webinar. My remit is to talk to you on distal radial fractures, which is quite a vast topic, but we're going to try to make something of it. Essentially, we need to understand a few anatomical features. Just get this to move on. So the distal radial anatomy, there are some important aspects of it. One of them is the inclination, which is about 23 degrees. The height of the distal radius, which is important, as you'll see, it's an average of 12 millimeters, and the palmar tilt, which is about 10 degrees. This is just a bit of revision for the trainees in particular, that when you carry out surgery of the distal radius, you have to be rather careful in terms of where you place the plate. It has to sit within the pronator fossa in a sense. The watershed line is well established as the point at which the plate must extend no further, but should extend to that point to buttress the lunate facet in particular. If you go beyond that point, you run the risk of FPL rupture. On the radial side is the radial tuberosity or the orbit tubercle, as well as the volar ridge. If you go too radially, the plate can be felt, and sometimes that's the reason why they ask for this to be removed. So you've got to be quite careful of where you place your plates. The other thing is that this concept of the 3 columns is well established, of which I'll point out to you that the intermediate, the central column, is a load-bearing column. More than 50% of the loading goes through there, and it participates in DRUJ, and it's crucial to reconstruct, buttress, and support this column. And I think the essence here is when you look at distal radial fractures, whether it be extra intra-articular, is this stable or unstable? And the key radiological features for instability are significant comminution, angular deformity more than 10 degrees, shortening more than 5 millimeters, and articular displacement of step equal or more to 2 millimeters, and misaligned distal radial joint. I emphasize the word misaligned because it need not be completely congruent, but it must not be unstable. And Chung et al. Produced a good paper back in 2007 on the predictors of disability at 3 months. And the strongest predictors were the incongruity of the articular surface of the radius, residual dorsal angulation, and from functional perspective, it was lower income as well. The first 2 in particular I've noticed are quite important. though they tend to slightly improve as you go up to a year. And for the stable fractures, I think a plaster or a splint is quite adequate. You may often do a manipulation with a plaster, and that is, of course, the commonest treatment. And in some circumstances where there is potential instability, one would advocate a percutaneous wire and a plaster. The unstable fractures, on the other hand, would require, commonly the workhorse is the wrist plate, whether it be volar or dorsal, based on the characteristics of the fracture. And you may supplement with bone graft wires or X-fix if you have a more complex fracture. And if it is not reconstructible, then the new kid on the block is a spanning plate, which has clearly replaced the X-fix, which has a lot of problems. And what about K-wires? The draft study in 2015 suggested that there was no difference between K-wires and plating in a prospective randomized multicenter study where they divided them into two groups randomly. But one aspect of this study is the pragmatic study. The patients that were excluded were those where the surface of the wrist joint was so badly displaced that it required open reduction, and therefore it came in for some critique. I would point to the paper of Susan Fulilove in 2016, where a critical appraisal on the changed practice in the UK suggested that potentially the surgeons were unduly influenced by its headline conclusions. And a more recent paper by McColgan in the BJJ in December 2019 suggested there was now an increasing trend towards open reduction internal fixation as opposed to wires. This may be because of the complexity of the fractures we pose or the problems with wires as well. I think it's fair to say that K-wires are very useful in the potentially unstable extra-articular fracture with good bone stock. I emphasize that because if you got somebody with osteoporotic bones and you fix it with multiple wires, as in this case, this lady unfortunately landed up with a very poor outcome with an infected pseudoarthrosis. So really that's not the suitable treatment for that. On the other hand, we look at the intra-articular fractures. Some of them are simple intra-articular and can be treated, just a hairline through, of course, with a cast. But if you have an unstable intra-articular fracture, you should not cast it because the palmar flexion used to restore the palmar tilt will result in depression and displacement of the volar lunate facet, as this diagram demonstrates. And therefore, the unstable fracture pattern can be initially the commonly seen one, the extra-articular one in a 60-year-old patient. This is the common age group, a fall on the outstretched hand, and they have a classical dinner fork deformity. In these sort of circumstances where there is very significant shortening and a review of the bone stock and taking that into consideration with the extent of displacement, perhaps the workhorse for this is a volar wrist plate. And the approach commonly used is the modified Henry approach. I tend to use this almost routinely. Registrars need to be aware that the median nerve is only about 8 millimeters medially, and similarly the radial artery is about 8 to 10 millimeters radially to the incision. But otherwise, I recommend it. It goes straight down, and different options for managing the pronator, but it really doesn't matter whether you repair or you don't repair, or you go through the middle or through the edge of it. It provides excellent exposure to the distal radius. And this is the picture of the patient at 3 months. She did very well. The plate used is a column plate, but it really doesn't matter what plate you use as long as you've got adequate compression and locking screws through. You restored the height and the inclination and the congruity with buttressing of the central column or the intermediate column with the screw in the radial styloid. And Madder and Penning in 2006 emphasized the importance of CT scan in intra-articular fractures. And this is a CT-based classification of 1 to 5. And if you look at this, it provides different patterns of this fracture. And this might not be the entire remit of it, but it really emphasizes that we have to recognize these patterns and decide on the appropriate approach to treating them. It recognizes instability at the fracture level and the impact on the distal radial joint. And I'll show you two different patterns. This is a young man who came off his push bike. He has got an intra-articular fracture of the distal radius. And you can see there is some degree of depression. There's some involvement of the lunate facet. You really need a CT scan. And this taken in 3 planes. The coronal axis and sagittal shows the extent of involvement of the DRUJ and the volar displacement of the end of the radius. And this would be ideally managed with a volar locking plate with adequate number of buttressing screws. This provides compression. So you use some distal compression screws and combine it with locking screws, and provides a subchondral support as well. And this patient went on to make a very good clinical result. So a plate applied palmally to the lunate facet, it reduces and mortars both the DRUJ and the radiocarpal joint. On the other hand, this is another young patient in her 40s, and she had a trip and a fall. She's had this dorsally fractured distal radius. There is depression of the articular surface, almost similar to a tibial plateau, and it's almost semi-subluxated. This is completely unstable. This was required to be fixed, and in these circumstances, I had no hesitation in using a dorsal approach where you can inspect the joint surface, elevate the depressed fragment, and fix it with a frame plate. In this case, she went on to make a very good clinical result as well. Sometimes they are very high velocity injuries, as this one is. You've got splintering of the bone in all directions, as emphasized by the CT scan over here, and you really have to combine various modalities. I tend to use finger traps in particular. That's very useful as an aid to reduction, using K-wires as temporary transfixation and using AO principles. And finally, the fixation using a long plate. So it's an adequate fixation, and you have achieved the fixation of the styloid as well as the ulnar or the lunate facet. You can use some of the variable angle screws in a toggle manner, which helps to produce intra-fragment compression. And this patient went on to have a very good outcome clinically. So my message is, first of all, analyze the fracture pattern in all intra-articular fractures via CT, and then use the correct plate. It's not necessary to use a volar plate in all circumstances. A dorsal plate also works well. Recently, I was on a seminar with Scott Wolf, and he tends to be using much more dorsal plating nowadays. As he says, it's much better at reducing all the components of an intra-articular fracture. The important thing is always buttress the die punch fully, whether it be dorsally or volarly. And restoration of height, palmar tilt, and articular congruity is vital to the clinical outcome. You must check and restore the function of the distal radial joint and the ulnar head for its integrity and its adequacy reduction. What you don't want is instability there. If you've got some instability, you can use a transfixing wire. K-wires are useful in the young or those with adequate bone stock, but not in the elderly or osteoporotic bone. I would tend not to use that, but rather a plate in those circumstances. Thank you very much. This has been a whistle-stop tour on distal radial fractures. I would like to thank Abhinav and the entire education team at BIOS. I would also like to, as the incoming president of the British Indian Orthopaedic Society, encourage all the trainees who are eligible to visit the website and enroll as a member. And thank you very much once again.
Thank you very much, Prof Tolat. There are no questions on the chat, so I'll just ask a quick question. I think you've already answered it. Dorsal plating, I completely agree with you. There is a very important role it plays in certain types of fractures. In your experience, how often do you have to take the plates out?
Yeah, this is a good question, because when I was on this webinar, this came up for discussion. And to be honest, with the newer low-profile frame plates that are available, or fragment-specific plates, the sort of, the risk of plate removal has perhaps been overemphasized. You don't need to remove them excessively, I would put it that way. Personally, I would say that I have removed probably 1 or 2 plates out of probably 30, 40. So it's like 3 to 4%. The bottom line is that if you do have a problem, then you would probably, like tenosynovitis, which is the common sort of presentation, if they've got irritation, it's fine, you can take them out, I suppose. I think the key issue really, which I wanted to emphasize, is that one should not be dogmatic, and one should really look at the fracture pattern and select your plate. And therefore, it's far more important to get the fixation right, and whether it be volally or dorsally, rather than worry about the plate.
Excellent. One more quick question, Prof. When you do your volar approach, do you repair the pronator quadratus? And if you do, then what's the advantage of doing that?
Yeah, again, this is a question that's done to death, really. I think the trainees may be asked from time to time as well. There is absolutely no evidence. The view across the world, it's interesting. In Europe, the Germans always repair it. They say we go through the middle and we repair it. The Americans say, forget about it. There's nothing to be done. And I think my personal experience is that it probably makes no difference whatsoever. I think it looks nice to cover a plate if you've got good muscle there to repair it, putting in a few stitches. But I mentioned in my talk that there's no evidence to suggest whether you go down the middle, you go through the edge, whether you repair it or you don't repair it. No difference whatsoever. And I think the trainees should stick by that if they're asked in the exam.
Perfect. I think Amar might have a question.
Hi, Prof. Thanks.
Hi,
Enjoyed your talk. Just a quick thing, because I think it probably come up in the exams as well for the trainees, is regarding treatment of the ulnar styloid fracture when you've done the fixation of the radius. I always assess the DRUJ on table and then decide whether or not to repair the ulnar styloid, rather than always fixing ones which are, large fragments. I wonder what you do.
Yeah, thanks, Amar. Because of time, I didn't go so much into the DRUJ, that's a separate talk really. But the evidence on ulnar styloid, if you take ulnar styloid fractures in isolation, and when I say isolation in combination with distal radial fractures, but if you just look at the ulnar styloid and the fracture of the base of the ulnar styloid, there is an increased risk, of course, of TFCC injury and potentially making the DRUJ unstable. Now, the evidence suggests that if you have an ulnar styloid fracture, the radius fracture would trend towards a worse outcome, but there is really not much difference as long as the DRUJ was not unstable. So I think it would be fair to say that on table, you need to assess it. And if you've got a basal styloid fracture with an unstable DRUJ, then repair of the ulnar styloid on table would be a good idea. But not if it was a tip fracture, and not if it was a basal fracture with no instability of the DRUJ. I think again with the DRUJ, I did mention the DRUJ as a joint is incongruent anatomically. So it's wrong to describe congruency as a landmark or a point to be reached. What you're looking for is instability of the DRUJ. So if you have some incongruency, but the joint is stable, then clinically it doesn't seem to matter much at all.
Yeah, thank you. I agree. And the other thing about examination of instability, I find it very useful to, before I start surgery, is to examine the uninjured wrist and see what the kind of natural movement of the DRUJ is in that patient, and then compare that to the injured side once I've stabilized the radius. And that gives you a good idea of whether there is instability for that patient, because obviously different laxity the patients will move that ulnar head in a different amount.
Correct. I mean, it depends on the laxity of the surrounding ligaments in terms of what the natural anteroposterior glide of the DRUJ or the ulnar head is. One useful test, and I'll just show that up if a trainee is interested, is, sorry, I just turned it, is to deviate the wrist onto the radial side, okay, and then ballot the ulnar head. So in your own hands and wrists, if you were to do that, you will find that in the ulnarly deviated position, the ulnar head ballots anteroposteriorly. That's the normal glide. But as soon as you turn it into radial deviation, that movement is much reduced. So on table, if you turn your wrist into radial deviation and then ballot the ulnar head, it will tell you more or less straight away that there has been instability. You know, if you get it moving up and down, then that's definitely unstable.
Thank you very much, Amar and Prof Tolat. Running short on time, so we'll move on to the last talk delivered by Karam Al-Tawil, who's one of our upper limb fellows at King's, fairly experienced in hand and upper limb surgery, so I'll let him crack on.
Ulnar-sided wrist pain following trauma. This is often quite a complex and challenging topic with difficult principles. It's not very well covered during training and presents difficulty in diagnostics and management clinically. One way of looking at it is to split it into direct and indirect causes, and within those to look at the bony and the soft tissue elements. In terms of the bony elements, there's ulnar styloid fractures, distal ulnar fractures, and other smaller fractures such as a tracheal avulsion or hamate fractures. Soft tissue, the mainstay there is the TFCC injury, also to consider lunar-tracheal ligament injury, and ECU injury and subluxation. Indirect causes include problems with the DRUJ and also distal radius fracture malunion. Looking at the distal ulnar in detail, it articulates with the radius at the DRUJ and also with the TFCC distally. It has two eminences. One is the head, which can either be concave or flat in configuration. The green arrows there show the insertion of the TFCC, and the blue arrows point to the location of the ECU tendon and subsheath. There's also the styloid process, which is extra-articular, and that is on the dorsal ulnar aspect of the ulnar, of the distal ulnar. Also note the TFCC insertion, which is into the fovea, which is important for DRUJ stability. In terms of fractures, they can either be for the ulnar styloid isolated, but that's very rare, or in association with the distal radius fracture, which is the much more common scenario. They can be classified into either the tip, which would not involve TFCC, the base, the fovea, which would involve the TFCC, and more proximally going into the metaphysis. Some of the presenting features might be pain on grip and also weakness, limited range of movement. The majority of these ulnar styloid fractures do go into non-union, but not necessarily become symptomatic. In terms of the investigations, start with plain X-rays, a CT scan to determine the position and the size of the ulnar styloid fragment. And if there's worry about the TFCC attachment, then an MRI scan would be helpful. Management-wise, most of the literature point to taking a conservative approach to these fractures. In the presence of a distal radius fracture, fixing or leaving the ulnar styloid fracture does not seem to have any effect on clinical outcomes in terms of pain, range of movement, and DRUJ stability. There was also no difference in the outcome of the distal radius fracture's fixation in the presence or the absence of an ulnar styloid fracture. These should be addressed on an individual basis, and they mostly relate to DRUJ stability. For the base type fractures, it is suggested that if the displacement is more than 2 millimeter and it's in a radial rather than a distal or axial direction, there may be an indication there to fix it. Symptomatic non-unions can either be excised if they're a very small fragment or reattached if there's no DRUJ stability, and they need to be fixed if there is a DRUJ instability. Options include using tension band wiring, using K-wires, a plate with a hook, suture fixation. All these techniques have their own benefits and disadvantages, including rotation of the K-wires or the screw, or the fragment rotating on them, and metalworker rotation from a tension band type fixation. With regards to the distal ulnar head fractures, congruity in the DRUJ is the key determinant here. Mostly would require open reduction internal fixation. Plate fixation, the plate positioning is best on the volar aspect of the ulna, just volar to the ECU tendon. This is one case which we did a few months back. This is the best image to evaluate this, which is the axial CT showing the incongruity of the DRUJ and the flicked fragments. We fixed it through an ulnar approach with headless compression screws and a plate as well. Next, we move on to the TFCC, which is a complex structure that functions to stabilize the DRUJ, transmit load on the ulnar side of the wrist, and also stabilize the ulnar side of the carpus. It has multiple components. The disc proper is the horizontal section. Around that, there are the volar and dorsal radio-ulnar ligaments, which provide the stability for the DRUJ. There are also ulnar-sided collateral ligament and volar ligaments, which include the ulnar lunate, ulnar tricutal, ulnar capitate. There's also the meniscus homologue and the ECU subsheath. The attachments are deep into the foveal base of the head of the ulna, or superficial, reflected onto the ulnar styloid. And this is important when evaluating injuries and also evaluating fractures around the ulnar styloid, as it can affect stability. Palmer classified these into traumatic, so type 1, or degenerative, type 2. So the type 1s, A is a central tear, B is a peripheral ulnar-sided avulsion type tear, C is a volar ligament disruption tear, and D is a disruption of the base of the TFCC from the ulnar side of the distal radius. Adzai also classified these later on based on management rather than anatomy, as with the Palmer classification. Presenting features can be difficult to diagnose, but includes pain on grip and also a click on pronation and supination. There are multiple examinations and provocative tests that can help elicit and diagnose a problem with the TFCC. Investigation-wise, the mainstay would be an MRI scan, and also sometimes an ultrasound scan can be employed, but really the gold standard is arthroscopy. It is also important to look at the ulnar variance and its relation to the TFCC, as this can have an impact onto the thickness and therefore the likelihood of injury to the TFCC. And those with a positive ulnar variance will have a stretched, thin TFCC, whereas those with a negative one will have a thicker and shorter ligament, therefore less susceptible to injury. Treatment-wise, start with conservative management. If this fails, then progress to arthroscopy. For central tears, the treatment is debridement, really. As you can see from the bottom right-hand corner, the blood supply to the TFCC is only to the peripheral rim, 20%. So the central portion is avascular and therefore not amenable to repair, but to be debrided to a stable edge. The peripheral tears can either be arthroscopic assisted repair or open repair. With any of these, it's important to ensure that the dorsal branch of the ulnar nerve is protected at all times and not injured. In terms of techniques available, it's important to repair the TFCC in a supination and extension. Ulnar-sided type avulsions can either be fixed with an anchor into the avulsion site, into the fovea, or through a drill hole and fixation with an knotless anchor more proximally to give a sturdier repair. Radial-sided tears, again, can either be fixed with an anchor into the ulnar edge of the radius, or through bony tunnels, or going around the radius and tying the knots on the outside, on the radial side. This is one case, which again we did a few weeks back, of pain and instability, and as soon as we opened up, this is a dorsal approach, the ulnar head bent back dorsally. We put anchors and onto the ulnar head, and also onto the radial, onto the distal radius. And as you reef the TFCC in the capsule, it stabilizes it. Very briefly, just to mention about ECU, it can be a source of ulnar-sided pain. Look for the click and the subluxation when the forearm is supinated. The ECU goes into a more dorsal position, and as the forearm pronates, it reduces into a more volar position, as you can see in the bottom right-hand corner MRI images. Management-wise, again, attempt conservative measures. If these fail, then reconstruction can either be anatomic or non-anatomic using the retinaculum. And finally, regarding lunar tract retrial injuries, assess these with an MRI scan, and first with an X-ray to look for a visi deformity, which can either be static or dynamic, where the lunate direction is in the volar direction. Management would include again conservative measures with splinting and injections, or a surgical repair for acute injuries, or reconstruction for more chronic ones. These are some of the references that I've used for this talk. Thank you very much for listening.
Great. Thanks, Karam, for an excellent talk. Are you here?
Yeah, I'm here. Thank you very much for inviting me to give this talk.
So I don't think there are any questions from the chat side. Question from me. I commonly see this in my clinic. We get these fairly active ladies in their late 50s or early 60s, sometimes even in the late 60s, who have had a distal radius fracture managed non-operatively, and that has united in shortening and radial deviation, and they come with ulnar wrist pain. What's your advice on managing these patients?
I think again it will depend on an individual basis and what their level of activity is and how much of an issue this is to them. If they have significant issue there in terms of if there's shortening, then that could be due to ulnar abutment. So again, I would get investigations first, start with X-rays, and then if we do suspect clinically that there's an issue with the TFCC, then we can get an MRI scan or even an MRA, so a arthrography of the joint, because that's more specific and sensitive in terms of diagnosis. But ultimately, they are either going to be managed conservatively with like an injection, splinting, and activity modification, and accepting the level of symptoms that they have, or then they probably will progress to arthroscopy to diagnose and see if there is a central tear that can be debrided, or then if there's a peripheral tear that can be fixed. But I think with age and less demand and less activity, people would veer onto the conservative side of things. I'm not sure what they're thinking from the rest of the panel is on this.
Abby, can I come in?
Yeah, sure. Thanks, Saurabh.
No. Thank you, Abby. Thanks, Karam. Great talk. Abby, as you said, we do see it because we both work in the same hospital, same sort of patient profile. Distal radius elderly people, sort of mid-age to elderly, they tend to be kind of neglected a bit, if I may say that. Like draft study, give them a plaster, fracture slips, they are seen at week 4. By the time it's too late. Like we do. So few things here, as Karam said, I agree on all the points, depending on the shortening. So if it's very short, then you need to address the radius component. That's where the problem is. That's where you need to do a corrective osteotomy. This is for the trainee registrars. And then coming to what Karam said, if the shortening is, and again, in terms of shortening, you need to see the sigmoid notch. If it was an intra-articular fracture, how the notch is in relation to ulnar head now. So even when you're doing your distal radius corrective osteotomy, the congruity has to be there after you've got the radius out to length and angulation. So your axial CT cuts helps you a lot in your pre-op planning. Then coming to Karam's point, if the shortening was not a lot, then other issue is ECU tendon. Ulnar styloid, if it was fractured, it has rough edges. And then two things happen. ECU has to take a longer course, gets tired and irritable and gets tenosynovitis. And the sharp edges can irritate ECU tendon. So that's another issue that may have to be addressed. And then as Karam said, MRI, by and large, if shortening is not a lot, sort of your wrist scope, TFCC debridement, maybe a wafer procedure if needed. So all those factors have to be considered. Answer is not, I'll shorten the ulna, bring it out to radius length and job done. Address radius if it's markedly shortened. Think of TFCC, think of wafer, think of ECU tendon.
Yeah, absolutely. Thank you for that comment, Sarab. And again, from the exam point of view, the best thing to do is to correct the original deformity and correct the distal radius rather than create another deformity by shortening the ulna and leaving the distal radius deformed as it is, because that's just going to create more problems rather than solve the initial problem. And we also have to be careful in the elderly population, because there has been a study which looked at about 100 patients, scanning them with an MRI, to look at the TFCC, and there was about a 30% rate of non-symptomatic tears. So pretty similar to what you'd get in the shoulders, where if you scan, let's say 100 people over the age of 60, 50% will have a tear that they won't be symptomatic or aware of. And actually some of those TFCC tears that they scanned were full thickness tears and still asymptomatic. So again, all goes back to the patient, to the symptoms they're complaining of, a detailed history examination, investigations before you jump in, because ulnar-sided pain is quite difficult to deal with. And if you take the first wrong approach to it, it might lead into a whole world of pain for both you and the patient.
Thank you, Karam. Amir, do you want to come in? You raise your hand.
Yeah, all I was going to say is in my experience, ulnar-sided wrist pain following any kind of radius fracture is really common. Having had a wrist fracture myself and a volar plate, I know it was sore for a couple of years, and instability as well. I think a lot of people get a degree of instability of the DRUJ, not to the point where necessarily needs intervention. But I certainly noticed a little bit of instability, and I think that there is that whole gamut. I mean, we don't understand a lot of what goes on the other side of the wrist with all of the ligaments and the TFCC and the capsule and the ECU and all of that, which all together help to stabilize it. But individually, you can get pain there. So I agree. I wouldn't rush into doing surgery or debridements, etc. And all these patients that came in with that group that Abby talked about, the 50-year-old, because my clinic would be full of them. And the other thing as well is, yes, I agree in that I try to correct the radius, but if the radius is just short but neutral, I favour doing an ulnar shortening osteotomy. I've had my fingers burnt a few times now by trying to lengthen the radius with grafting, etc., and had multiple operations with patients doing a bit too much and the plate breaking and having re-ops and whatever you. And I find ulnar shortening osteotomies are a very simple operation, and my non-union rate for those is quite low. And with the newer plates now, the lower profile ones, removing the metalwork rate is quite low as well. So don't dismiss an ulnar shortening osteotomy as a way of trying to improve ulnar-sided pain for people with proven abutment with failed non-operative measures.
Thank you. This is perhaps the last question. This is from the chat. Rahul asked this question. He says that the TFCC diagnosis in general, this question for the faculty, Amir and everyone, how do you think they do clinically following surgical repair or debridement in general, TFCC repairs, especially if they're chronic?
I think, this is a group of patients that generally, from symptoms to diagnosis to treatment, they normally have a really prolonged history, and they can be several years from when they first presented to when they actually end up treatment. And therefore, like with other chronic pains, with back pains and chronic knee pains, etc., they're not a group of patients that I normally expect them, or that they're all gonna have a really high satisfaction rate. I think you've got to really counsel these patients quite carefully. And I think they have to have realistic goals. And for them, their realistic goals is to improve their instability, but to have some degree of discomfort, because they're going to get scarring around there. I favour doing the open repairs. I find I struggle with doing these arthroscopically. And I think if you pick your patients carefully, like you do with a lot of these chronic problems, you pick your carefully and on your investigations. And I find with our imaging department, with MRI arthrograms or CT arthrograms, we can get a very high degree of accuracy of where the TFCC issue is, if that's the problem. Then I don't need to do as many diagnostic arthroscopies for these. Sometimes in the interim, doing an arthroscopic debridement I find does actually help in some of these patients with repeat synovitis that respond well to having an injection initially, and that's another kind of interim operation that you can do, and you can see which group of patients you think are generally well motivated and going to do quite well. But by and large, you can't say that 80-90% of these are going to do brilliantly.
Thank you, Amir. I'm conscious of time, so Amir,
Sunil,
thank you very much.
Sunil, there was one question that was repeated a couple of times about why proximal pole fractures do not go into SNAC. It was directed at Saurabh.
Yeah,
Okay.
sure, I can take that.
Yeah, go for it, Saurabh.
Right, okay. So, so it's a stable injury. Proximal pole is very small. It's wedged into your scaphoid fossa. Force transmission is such, the axial loading is such that it's a stable fracture. So like your stable waist, is not going to tip into a humpback. Your distal pole will not flex. You will not get a disi. You will not get a humpback. You will not get a bone loss on the volar surface. And also remember, especially for exam, proximal pole, you're going dorsally. It's a dorsal approach. From dorsal approach, you cannot correct humpback because you need to put your graft from the volar surface once you've corrected it. So proximal poles don't get humpbacks. They are stable injuries. All they get is sclerosis. They can get dorsal spurs, which can give pain on extension because those spurs, those osteophytes hit the dorsal rim of radius. And occasionally you can get arthritis in the radial styloid process. You don't get a SNAC 2, 3, 4 humpbacks disi. So that has to be very clear in proximal pole. I hope that addresses the issue. Sunil, can I say one more line just to finish?
Sure, please. Yeah.
So like the question you asked me about the scaphoids and the MRIs in A&E, only one more thing to add here. In young people, less than 20, 16, 18-year-olds, a scaphoid fracture is a very different kettle of fish. In a A&E or otherwise, if it is missed, i.e. a plaster is not given or this is dismissed as a sprain, within a matter of weeks, they have a marked humpback and a bone loss on the volar surface. So if you see a young person less than 20 or thereabouts, they should be sent home in a plaster slab. Then there's no movement. They're not moving the wrist. You can do an MRI at 2 weeks or whenever you want to.
Yeah, sure. I mean, there was talk about doing a quick sequence for these occult fractures where you have scaphoid tenderness in the anatomical snuff box in the tubercle and you have the axial grinding positive. So, and your x-ray is negative. So you have a occult fracture and if you're highly suspicious, and if, as you say, if it's a young person, there's now a lower threshold for people considering these very quick sequence MRI scans, which are not as expensive, but obviously everything depends on the availability, as you said in your talk. So, well, Saurabh, thanks a lot for your tips. Amir, thank you very much. Kareem, thanks very much. And Amit, as always, excellent tips. So, and many thanks to my co-host Abhinav, who has put this all together, and obviously to a president, and Manish Bhatia, who is the educational chair, who's running the entire series of webinars for the trainees. So we hope to send an edited version of this recording on the YouTube channel of BIOS, so that people who have not been able to come and visit us live can watch this in their own time, and then also give us feedback on the topics that they've heard today and for future. So I'm really thankful to all of you gentlemen for sparing your valuable time on this slightly rainy Sunday afternoon. Thanks ever so much, and goodbye.
Thank you very much, everyone.
Thank you.
Thanks.
Thank you, guys. Good to see you.